Welcome back everybody to another video of our nephritic syndromes section. So now we're going to talk about something called IgA nephropathy. And the pathophysiology of IgA nephropathy, as you could probably guess, involves elevated levels of IgA antibodies typically following a triggering event. Now keep in mind we typically have normal IgA in our body. However, in this particular pathology, we're developing an abnormal type of IgA. And although the reason for the development of this abnormal type of IgA is not really well understood, it should be noted that we have an increased risk for developing this condition anytime we have an event in which we would typically increase the production of our IgA in the body. So remember, IgA is an immunoglobulin that's typically elevated during a type of infection in the body, particularly respiratory or GI infections, because IgA is part of our immune system and it's most densely located in the respiratory and intestinal tract. So if we get something like an upper respiratory infection, we're going to see an increased synthesis of IgA antibodies following a triggering event. This triggering event most often includes an upper respiratory infection or GI infection. Also, just as a quick point for completeness sake, keep in mind that IgA typically presents as a dimer, which is different than some of the other immunoglobulins in the body. So as with most of these conditions, right, we're introducing an injury or an insult to the glomerular filtration barrier. And what happens is that immune complexes form, ultimately depositing in the glomerulus. And this immune complex deposition can lead to damage to the kidney and the filtration barrier. Also note that this is a type 3 hypersensitivity reaction, which we know because this is an immune complex mediated reaction. And this is different than our type 2 hypersensitivity reactions, which simply involve an antibody binding to a cell surface antigen, like what we would see in Goodpasture syndrome. So again, this follows our general theme that something occurs in the body, a reaction that damages our filtration barrier, and then we are presented with a nephritic syndrome, in this case IgA nephropathy. So the diagnostic principles of this disease include things like taking a history, doing a physical exam, but as with all of these renal pathologies, we can ultimately get a kidney biopsy. Of course, this is not our preferred method for diagnosis because it's invasive. However, it is important to be familiar with a couple of findings that you might see in IgA nephropathy. So you might see mesangial proliferation on light microscopy. You might also see this on electron microscopy. But the main one I want you to know here is that you can see immune complex deposits on immunofluorescence. Remember, if something lights up on immunofluorescence, that typically means there's an antibody involved. And it's helpful to compare and contrast diseases and pathologies which do not light up on immunofluorescence or are posse-immune versus those that do, because this can be a key differentiating factor when you're trying to narrow down which is the most likely diagnosis for this patient. Recall that this is one of our nephritic syndrome pathologies, so other labs that we might get to work up this patient include a urinalysis, which we would expect to show us things like proteinuria, hematuria, or other findings that we would typically expect to find in a glomerular disease pathology. The management for these patients really includes symptomatic management. I think it's really important to know with most of these renal pathologies that it's hard to reverse disease. What we're really trying to do is slow down progression of disease. That is to say, once the kidneys have been damaged, they really can't be repaired very well. And thus treatment is focused on preventing further damage and ultimately preventing end-stage renal disease. And so we can do this by giving medications like RAS inhibitors, which can help decrease the pressure and the amount of blood flowing to the kidney and potentially decrease the amount of inflammatory damage that's occurring as well. This can also decrease the amount of protein that we're losing in the urine and help with some of the symptoms that the patient might be experiencing. It's also important to note that you can use treatments like glucocorticoids, which again can help decrease the inflammatory response in the patient, but glucocorticoids do have a long list of adverse effects. And because of these adverse effects, they're not considered a first-line treatment. They really are used for patients with a very severe condition or severe presentation. Next, we're going to talk about some key associations that they want you to know for IgA nephropathy. It's important to note that IgA nephropathy is the most common primary glomerulonephritis in adults, and it most commonly affects adults in their second to third decade of life. And this is important information for us, right? Because when we talk about some conditions like minimal change disease, we typically expect a classic presentation or a classic vignette to ask us about a child, right? Does this mean that can only present in a child? No, it does not. However, typically questions use classic presentations or most common presentations, so we can compare this condition, which we would expect to see in a young adult potentially, with something like MCD or minimal change disease, which we would expect to see in a younger patient. It's also important to know the association we previously talked about is that this typically follows or occurs during a respiratory or a GI infection. And the reason is because our mucosal membranes, or our respiratory tract and our GI tract, are full of IgA. And so during an infection, our body naturally increases the secretion or the production of IgA. If we are, for a reason that we may not know, secreting an abnormal form of IgA, this can ultimately lead us to this renal pathology. Some other classic findings the patient might have include hematuria, flank pain, potentially a fever or respiratory problems, as well as signs and symptoms that might be consistent with a GI or gastrointestinal infection. It's also important to know that this pathology can be confused for some other similar but distinctly different pathologies. One of those includes IgA vasculitis. IgA vasculitis also commonly occurs after an upper respiratory infection. However, typically we would expect to see this occur in children. It might also include some classic findings, including arthralgias, abdominal pain, or something called palpable purpura, which you can see in this image right here. So this is a vasculitis that is secondary to immune complex deposition, and it is associated with IgA nephropathy. But you can see here there are some classic findings that are different than we would see in a true IgA nephropathy. In IgA vasculitis, we're going to typically see it in a younger patient, and I think one of the key clinical findings is this exam finding of palpable purpura. This is not something we would expect to see in IgA nephropathy by itself. And the final thing I want to mention in this video is another similar but different pathology that can often confuse students. And do you remember another pathology that we've talked about previously that presents similarly to IgA nephropathy, with the key difference being the time since symptom onset? That's right, post-streptococcal glomerulonephritis. In PSGN, we said symptoms typically present about 2 to 4 weeks after an infection, versus IgA nephropathy might be closer to 2 to 4 days. Again, these are relatively rough approximations, right? If a patient presents at 10 days, well, that's a bit of a tricky one where it could be either or, but as I previously said, test writers are typically trying to give you a classic presentation. So if they tell you a patient is presenting 3 days after an upper respiratory infection, that means they're likely leading you to IgA nephropathy, versus if they say a patient presents and 3 weeks ago they had an upper respiratory infection, that's probably leading you more towards post-streptococcal glomerulonephritis. So use these dates and these timeframes as approximations to help you get your questions right on test day.